think the great thing about all the things today is that we're actually doing very concrete things. We're not talking about theories, we're actually talking about very concrete examples. And I think that's the best way forward in terms of actually making things work. So we're going to actually go on to talk about more concrete examples from H2O's experiences to date. And I would like to, as I introduce you, perhaps you can come up and join me from there onwards and take a seat. I'm going to introduce the various speakers in our first panel. So Professor Dr. Matthias Rose, who's Medical Director, the Medical Department Division of Psychosomatic at Charité, Universitätsmedizin in Berlin. And he's representing the German H2O Observatory. Welcome. And then secondly, we're going to have Roberto Saldaña, Vice President of the H2O National Observatory for Spain and Director of Innovation and Citizen Participation in Eupati, Spain, so patient organization, and the EFCCA patient engagement. So he's representing the Spanish H2O Observatory. Welcome, Roberto. And then Dr. Herwig Ostermann, who is the Executive Director of the Gesundheit Österreich GmbH, the Austrian Public Health Institute, and he's representing the Austrian H2O Observatory, and you can see he's online. Welcome, Herwig. And then Herco Komens is Supervisory Board Member of the Health Outcomes Observatory H2O Netherlands Association. He's representing the Dutch H2O. Welcome, Herco. And then rejoining us is Anka Thoma, who you met earlier, from the European Patient Federation, Forum rather. And she's the Executive Director, as you know. And then last but not least is Yasmin Diaz-Guichot, who's the lead for Health Systems Transformation at the World Economic Forum. Welcome, Yasmin. So this roundtable, I think, is really from your experience, an introduction to everybody about really what H2O is about, how you've set it up, etc., and how it's working. So before we actually plunge in, we're going to have online some explanation of the governance, and you can see he's already there. So I'm very pleased to introduce Deepak Kalra, who's President of the European Institute of Innovation through Health Data, and he'll explain how H2O will safeguard the data and comply with the GDPR, the Health Data Protection Regulation at EU level. So over to you, Deepak.
Well, good morning, and thank you very much for inviting me to give you an introductory presentation, which I'll do fairly slickly. We've agreed roughly 10 minutes or just under that. So I'm just going to describe to you how H2O kind of works with the perspective of the patient in mind. And I'm going to jump straight in without a preamble. I'd like you to imagine that I am a patient with lung cancer and diabetes, and I care about having the best possible health and healthcare. And my care is being handled mostly by a lung cancer hospital and my GP who looks after my diabetes. And perhaps I hear about H2O by, from one of the clinicians caring for my lung cancer. But it's also possible that I might hear about H2O through a friend. In either case, there is a national observatory, and I'm in Spain, and I can look it up online and decide if I'd like to give a try to this H2O thing about which I'm just discovering. Now, using the website of the observatory, I can discover that there is an app that I could use that is approved by H2O to collect lung cancer outcomes. And I decide, because I think it sounds intriguing and interesting, that I will collect my own outcomes, and I understand that I can relatively easily see how my outcomes compare with an anonymous pool of patients who are matched to be somewhat like me. So that really does sound interesting. I register with the app, And the app developer informs H2O so that H2O Spain is aware that I've joined their club, and I decide to collect my outcomes. Now, things like my current health, the severity, symptoms of my lung cancer, my quality of life, how well I can perform daily activities, and any improvements that might have arisen through the course of my treatments. And this information is also held by the app developer, but also a copy of it is sent to the Spanish Observatory, to a data partner that the Spanish Observatory works with, who is effectively a data processor on behalf of the Spanish Observatory. That really signs me up to H2O, and I now become a proper member of the H2O patient data network. Now, assuming that I find that experience to be pleasant, I might also decide to do something similar for my diabetes. And I sign up with a different H2O approved diabetes app. And in a similar way, I collect my outcomes. H2O is aware that I'm also signed up for diabetes, and the diabetes outcomes is added to my integrated environment held by the Spanish Observatory, as well as each of the two apps having their own cloud storage of my information. Now, I decide, because I feel that it might be useful, that I'd like my lung cancer team to know about the outcomes I'm experiencing. So I inform the app developer of my lung cancer app that I would like to do that, and I tell them which is my Spanish lung cancer hospital. They inform the National Observatory, who in turn informs the data integration partner they work with, and that integration partner then establishes a channel that will allow the hospital to access those patient-collected outcomes. Now, we recognize that from country to country, the exact mechanism for that, whether it's push or pull or something in between, will vary. And so we're exploring open architectures that could allow diversity in the exact way that this information flows. Now, provided that that experience is positive, I might make a similar decision about my diabetes and say that I would actually quite like my diabetes data to go in the same way. But I want to jump on to the next point, which is about comparing the way my outcomes are unfolding with my clinical data. There is tremendous value in being able to do that, to see whether the changes in my treatment time-wise have altered in any way the outcomes I'm experiencing. So I agree that I would like to have access to my EHR data alongside my outcomes data. So again, this agreement follows the same path, and this time the information flow is more in the other direction, that through an agreed mechanism, which will need to be country by country agreed and possibly hospital by hospital agreed, certain amounts of data, not everything in the electronic health record, but the data that is most relevant to interpreting my outcomes is extracted, such as the assessments of my cancer, its severity and any complications, investigation results. And you heard from Elena just a few minutes ago how powerful it is to link outcomes to clinical data. In the case she described, T-cell findings and so on. So this coexistence of the EHR data and the outcomes data is a tremendous value, we know, and we want to enable that through H2O. Now, the next piece in the story is that I decide that these outcome comparisons I've been benefiting from are actually useful, and I'm willing to trust H2O to add my own outcomes to their pools of data. So we don't make that a requirement when you sign up, but once you're comfortable, you could say, yes, please, you use my data as well in this anonymized way. And so now a slightly different data flow is enabled. So the pseudonymized extract that includes my data is now available to the analytics team, so they can create the comparative outcomes and pooled anonymized data sets and offer these back to the app developers from time to time, so that when I'm looking at the charts, my own data is added to the charts of many other people to see how my outcomes compare with the population averages. The next thing that might arise is that I also agree that my data can be used anonymously for health and research organizations to improve quality of care, quality of service, and also to further advances in drugs developments, AI, which has already come up a bit today. So again, I tell the app developer, I inform H2O, H2O tells the data integration partner, and now the Spanish analytics team is not just creating outcomes comparisons, but doing other analytics reports that serve the health system in Spain. That could be healthcare providers, it could be health insurers, health payers, it could be HTA or medicines regulators. It may be accepted in some circumstances that those bona fide health system and research organizations can run queries themselves on the pseudonymized data. And as you gather from Tanya's opening remarks, there is also a European observatory cooking right now, and that European observatory would be able to run federated queries across multiple national observatories to give us a European perspective on outcomes. And we will explore sensitively and with care whether any patient-level data extracts can be made available country by country for research organizations to have. Just a couple of other scenarios to mention: that this patient is moving or has moved from Spain to the Netherlands and actually enjoys the H2O experience enough to want to sign up in the Netherlands as well. So they can inform the Dutch observatory that they've moved over from Spain, give them some credentials, inform the Spanish observatory to authorize a transfer, and then the Dutch observatory can have the longitudinal data that I've built up over some years, perhaps in Spain. I can log in at the Dutch observatory end, download the appropriate app, and start to collect outcomes in a new app, but with all of my historic data at my disposal, thanks to the standardized approach of the H2O ecosystem. We will again need to be careful about how cross-border data transfers may be permitted. And so we'll obviously be able to start relatively easily with the patient-generated outcomes, and we'll explore how best to transfer EHR data, which could take advantage of the European patient summary, which is being strongly promoted as part of the European health data space. We'll explore that in the coming weeks and months. Finally, just as a small point here, the possibility that patients may want to empower caregivers to also have access to their data. This could be, in this case, the person who's wanting their son to have access. It could equally, in reverse, be a child with diabetes who needs a parent to be able to access their outcomes and so on. We recognize there are quite a lot of identity issues that we need to resolve, and we are therefore saying we're keeping this on the table. We will definitely aim to achieve this, but we might not deliver it as the earliest feature we put into practice. Now, I was asked if I would briefly mention how we comply with the GDPR, and I hope you've sensed that already. But in summary, the patient is always free to change their mind about the choices they've made. We have transparency about the data that is being held in the ecosystem, the purposes. Patient always has the access to it, the ability to correct it, have a copy, agree for it to be sent to any other player, and of course, for the data to be held unless the patient says, please delete my data, I no longer want you to have it. This is all work in progress. We are in the middle of engaging with patient organizations and other experts to help us to get this story right. And so I really welcome the panelists' feedback, because we are still at a stage of wanting a lot of feedback on how this resonates with you, or if there are any issues and concerns you think we need to take on board as we put all of these data flows into practice. Thanks very much.
Thank you very much, Deepak. I just wanted to kick off perhaps by turning to Herwig, who's online, to ask him basically what's the experience, as Deepak has outlined what the theory is, what's his experience on the ground with the Austrian Observatory?
I mean, thank you very much, first of all, and thank you also for having me here online, and thank you for this valuable input. I mean, what I think, first of all, is that we have a very ambitious aim here here in this H2O project, and I think in a sense it is also unique, you know, bringing together not only academia but also industry and of course also public institutes. And I think we need this kind of public-private partnership in order to integrate or to benefit from the full integration of data. For the Austrian case, we are currently, you know, set up as an association, basically as a friendly society in a way. And we do have some consensus in a way that, first of all, the public sphere, along with academia, has come together and has to come up with some ideas on how to basically share the data. And this would be the first step. And the next step then would be, so the first step would be linking routine data, electronic health records with patient-reported outcome measures. And the second step would actually bringing in also our partners from the industry. And I think it's a matter of building trust in first place. Also trust amongst the public bodies. There's not always a sufficient amount of trust between ministries and different spheres, so to say, in government. And I feel actually, you know, also with the benefits we see in this H2O project, that we have a very strong case. And the second opportunity, so to say, I see is actually the whole initiative with regard to the European health data space, which might give us a second push into establishing this kind of framework. So as a national public health institute, basically, we are not only a partner, we also see our role in terms of a facilitator with regard to our other institutions we have, for example, the society running the electronic health record, but also with the data we can bring in as a national public health institute that basically has access to our administrative data, not only from hospitals, but also from contracted physicians and so on.
Thank you very much. That's been very, very helpful. I wonder if we could move to another important issue that was raised again by Deepak, which is H2O's governance model. And we've also had, you know, a notice about the General Data Protection Regulation, and privacy obviously is a key concern, most of all patients. So I thought I could turn to Anka perhaps to give us some information and background as to the patient view of the governance model.
Thank you, Elaine. Deepak has Deepak's presentation I think it illustrates very well the way in the observatories, the data chain from the patient to the provider, app developers, processing, and then back to the patient represent one of the core principles of the observatory's governance, which is inclusivity of patients. And the fact that as a community we were able to contribute to this, to the creation of this governance, I feel it's really reflected in the way that data circulates. From a broader observatories governance perspective, I mentioned in the opening that the fact that patients have equal representation in the observatories boards, and that we were included in the design of this really signifies the commitment to patient centricity. But beyond that, the point of it is trust. Trust is the basis of data information provision, but also the basis of creating real value for patients. Again, this is the whole point of it. The governance principles of the observatories, including the inclusion of patient organizations, the consistency and comparison of data, the enabling patients as individuals and as community to be part in their clinical care, the matching the patients with the clinical outcomes, which is very important because in the healthcare systems, we have this reflex, we record clinical outcomes. Well, when you integrate patients, the trends become a little bit more nuanced and more person-centric. I mentioned the consent, which to me is very important to delivering the trust and the value to all involved in the chain. The reporting and the transparency of aggregated result is important. So it really is an empowering, person-centric framework that to me brings a promise of trust and real value to patients.
Thank you for that. Maybe I'll turn to Herco now, and perhaps you can give us some experience from the Dutch point of view on this point of governance and how it's working.
Yeah, well, what can I add to everything that's already been said? I mean, there was such a clear explanation of how it works, but I think one of the most important things here is that there's a shift in how we think about privacy.
Mm-hmm.
We move from protecting privacy, which is me telling you what you can do with her data, to respecting privacy.
Mm-hmm.
And I think that's a fundamental shift, and we couldn't have done that without having all these safeguards for privacy protection first. So this is the next step in the evolution of how we deal with privacy. And I think that in itself is a big experiment that we're all undergoing here, and that's why I like. I'm new to this family here, but I think that there's such a smart group of people, or group of smart people, both actually, that have created this amazing governance model, and now we really want to see it deliver. So that's why I think there's such a big push on just getting these observatories started, getting our hands dirty, our feet on the ground, and just doing it. And one of the things that happens when you shift from protecting privacy to respecting privacy is that you shift power. And that's the thing I think that's really happened in the governance of these observatories, is that it's not just patients have a vote, but that the rest of them, of the stakeholders, relinquish some of their power to enable everyone else to take that that responsibility. And I think that's what makes this so special.
Great, thank you. I mean, Germany is well known to have cultural issues around data privacy, which are quite strong and quite you know, well rooted. I just wondered if it'd be more of a challenge in Germany, or whether you're finding that the project there is experiencing the same sort of transformation that Herco's just mentioned.
Yeah, you see, I'm a researcher, so anything of a challenge is a good thing. So the bigger the challenge, the more, you know, we can work on this. So yeah, of course, you know, it's kind of an obvious fact that we do have, and there are good reasons why we are so cautious about sharing data and having data centralized in Germany. So it's so core to our you know, not always so happy history. So that's more concern. And whenever we meet with people from Denmark, from the Netherlands, we are, you know, as researchers, we get a little bit jealous how easy things can be if we are taking care of it. But to answer your question, so we are moving, and I think the H2O project is also helpful for us, for me, also being a clinician, you know, being interested that it works in the end, because, you know, in the end, you know, I'm motivated, you know, by making the lives of the patient better, but also being a scientist to play, I would say, the European card. So, and, you know, there are other people who have much more knowledge about, you know, how politics works. But for me, or for us in Germany, it helps tremendously to have the H2O project together and working in this kind of unique combination of people who are, you know, so knowledgeable to scale good ideas. So to cross the valley of death from researcher, have a good idea to make it really happening, big size. And so, and I'm totally, you know, and you know, when you talk offline with the regulators, they are obviously on board. It's just that they are very cautious, that everybody's on board, also the public, and that the separated sector in Germany comes together. And we have invested a lot of money in to speed up our digital infrastructure. So we are totally dedicated. It just needs a little bit more diplomacy at the moment, but we will go there.
I mean, I recall that in COVID, that was a big drawback in Germany, was the lack of digitization overall. So I'm interested, one, on that and how you've overcome that, and two, secondly, I suppose an overall question, how easy is it to get patients enrolled, and have you found that something that is coming easily, or how do you promote that to patients that this is a benefit at this early stage in the project? I don't know if you or others would like to answer that. Well, maybe on the German point about.
Yeah, or just Peter Gocke, he will be on the next panel. He's our CIO. He's much more competent than I am to talk about this. But of course, you're putting the pain points, and we are very cautious that and our CEO, he was very instrumental to create an entire network in Germany, which was heavily also financially supported, which is called the NUM, National University Medical Network, based on COVID, which I think was a major push forward to create the infrastructure. And we also invested. We have now the second funding phase for the Medical Information Initiative, which is also, again, another, I think, important initiative. And I'm happy to say that H2O already, helped us to get a large grant within the MIA as a sister project. So we are building up the ecosystem step by step, and with the support from the regulators. It's just when it comes to the legal parts, we need a lot. We have a lot of help, and we need a lot of help.
Yes, legal issues are always challenging. The next question I had anyway was about patients, so maybe I'll pass to Anke on that. Going back to my second question, which was, I'm fascinated, how you get people on board, and promoting, I suppose, the benefits is one of that. And that was my question really, is what are the benefits that you can broadcast to not only your association members, but more broadly in terms of the benefits it brings to patients, this whole health outcomes project?
How do you get patients on board? Well, it's not, you have to start somewhere. Okay, I'm a fan of gradual, solid, sustainable growth. I think the importance as the observatory start is to focus on a balance of participation and quality, so that you can continuously improve, and then as they demonstrate value, people will come. I think because this is also, it has to do a lot with apps and with data. We will continue to encounter these barriers of digital literacy, of data access. That is not a deterrent. It's just one of the challenges that I think as a broad community of stakeholders we have to encounter. Now, I do believe that the promise of this at the individual level for each patient, the ability to go there and compare your own status with the people in your disease area, disease community, I believe that is a very important motivator. But what we also know is that generally, as a community, patients are in favor of sharing their data for the benefits of others. So the potential benefit to the community, I think, is also a powerful motivator. You want to help others. We're wired, we're raised to help others as well as ourselves. So I think the altruism built in this, is a very powerful motivator. And the promise at the end is that things can get better for everyone. And so there is also the selfish one. I think this is a long-winded answer, but But I do hope it encapsulates our views.
Yeah, and I'll turn to Roberto now, who not only has a patient representative,
Yeah.
but also has experience from Spain. So perhaps you can give us some.
Okay, well, I think the implementation of the PROs have a lot of benefits.
Mhm.
We need to differentiate first what kind of patient we are talking or speaking about, because it's not the same that if we need to speak about a patient as user or patient as patient representative.
Mhm.
As an user, I can say that for me, it has a lot of benefits, like it improves a clinical trial result, a clinical practice, routine clinical practice, because people who report PROs understand better their diseases, understand better their symptoms. They can speak with detail what is happening to them. So it facilitates the communication with their physicians, and also the shared decision making.
Mhm.
At the end, what we are doing is improve the results of those practices. So we increase satisfactions, we increase outcomes, what matter most to us, and also quality of life. So that's amazing. We have even identified that, for example, that PROs are independent prognostic outcome, survival outcome in lung cancer, for example.
Mhm.
So that's amazing. So we need to keep asking patients what they are feeling all the time, so we can monitor them, identify the side effects, the evolution of their diseases, so we can adjust the timing even of their visit to the clinics. But as a patient representative, we also have some benefits, because if we have the true picture of what is happening to our community, we can also keep identifying unmet needs and start to work with our partners how to develop new solutions for them. So there are a lot of benefits independently of what role are we assuming.
Mhm. Mhm. Yeah, very interesting. I wonder from a doctor's perspective, Professor Rose, if you had a view on this in terms of the benefits for patients that you see from a doctor's point of view.
Well, absolutely. When you think it in a simple terms, you know, we are asking patients how you feel, you know, for thousands of years, probably. You know, and what we do here when we talk about prompts and prems, sometimes you think, well, this is kind of very complicated and, you know, rocket science, and you never know the treasure. But what we do is more or less, and Elena was alluding to this, you know, because it's how do you feel, and we put it into a number. So can you, you know, what is your physical function, which means can you walk up a flight of stairs? So it's nothing really, you know, complicated, but so essential to medicine as its core. And when you think of, well, the history of medicine over the last 200 years, we increased life expectancy, or we doubled this. You know, when the Charité was founded in 1610, it was 40 years. Now we have 80 years of expectancy. So the challenge for modern medicine will be, well, to make the healthy life years larger. So compressing morbidity, we talked about this detection of, you know, diseases earlier to enlarge the healthy life years. To compress morbidity is one term. We can use other terms, and this is where society all comes together. So the patients likes to have a longer, healthy life, and, you know, doctors are more happy, and in the end we pay less. So it's all comes together, and to make this happening, I think we do need those kind of initiatives to understand an early detection. So to come to your question, I think it's an essential part. If I treat a patient, you know, sometimes it will be me, maybe no, it's you, to follow my success. You know, my success is in multimorbidity, and chronic disease is not, you know, curing a disease. It is, you know, helping people to live with the disease longer, better. And in an empirical word, this is certainly, I would like to know the numbers. And, you know, I'm looking at laboratory results, so I'm looking at the health status, which is a totally natural thing. And that's what I want to like to stress. So we do something with this totally naturally. We just put it into some kind of transferring this to a new world, and hopefully make it again very easy, what we just heard. Hopefully we can make it as easy and just as it is the natural encounter.
I mean, I had a question as well, because I mean, the biggest health challenge facing Europe as well as most of the developed world is aging in demographics. And of course, conventional thing is digital literacy amongst aging populations. So I just wondered if you had some views of how you've managed to get over that. I was interested in Elena's example of the speaking, but then you still need to have your phone, or you still need to have a computer of some kind to get there. And I just wonder, with this sort of data project, how do you get to those people who are going to have the chronic illnesses, and and what part does the project devote to getting those people on board, the elderly populations as well? Anybody want to take that one? Roberto.
We know that there are some barriers to include every patient, and even we have identified that there are some subgroup of patients because of their age, because of their disabilities, cognitive impairments, or low vision, that can participate reporting PROs because of the burden. This is a challenge. Of course, the PROs can also be collected using other ways, other channels, by phone, by paper, but of course it's maybe not the best effective way to collect data. But we need to be very sure that we are not excluding any subgroup of patients, because their unmet needs need to be included, and we need to be very sure that we are covering their unmet needs, because if not, we are assuming a risk that being exposed to the consequences of their disease, or the impact of the severity of the diseases. So we need to be very sure that PROs are equitative, and we are including them. But there are different solutions. Technologies maybe can help us to solve many of them, but many? You are raising your hands, sorry.
You think, Roberto?
No, it's okay.
I couldn't help it but jump. This is not a project where we choose one technology.
Yeah.
This is a project where we create the rules of the game. So a lot of technologies can offer solutions. And I think the idea of being here today is to have some inspirations through the Microsoft technologies about what technologies can deliver. But it is my firm belief that if we create the right type of rules of the game, technologies are already there. Chat books, I mean, as Elena described it, potentially, but I have a more basic story, which is that in my older life, we always used to talk about this digital literacy for the older population until Apple came up. And right now, both my 90-year-old mother and my 87-year mother-in-law are begging for Apple Watches because they think that is the best possible companion for them in case they fall. And they have shown both of them in two different parts of the world with very different backgrounds, incredible capabilities to familiarize themselves with the Apple Watch, which I don't have, because they can see the value of it. So technology solves lots of problems if we create the right type of rules of the game so that they can deliver on it.
Yeah, thank you.
And I'd like to strongly support this.
Could you introduce yourself, sorry?
Yeah, Peter Gogger, CDO from Charité. I strongly support this. When we started PROM at Charité, we made the decision to hand over paper forms to every patient older than 70. And soon we get complaints from them. Because they ask, why do you force us to fill in a paper form and carry that to a post box instead of giving us this convenient app? And so we, of course, changed the decision. So I'm not that afraid that health literacy is a problem of age. It is in some cases a problem, but you can handle this.
Just very quickly, I think that, as Manny said, technology in a way is going to get there. The thing is, the design of the technology needs to really be thought for inclusion, for accessibility and usability. And with that, of course, interoperability and all of that. But if usability, and Apple is a great example, I mean, it's so convenient to use, right? The only thing is that together with all of this, it needs to be affordable as well. right? So put it all together. We know that if the design is correct, then the technology will emerge. But we need to make the rules of the market very clear in terms of what's needed.
And
Yeah, we were both in Boston a few weeks ago, and there was a presentation there at the H2O conference about people with club food in India. I'm not sure if you saw that. And they don't use technology to get to those people. They use the consultants that they already have in the field that are now in touch with these kids with club food, and they will help them fill in these prompts. And so it's not just technology that has to solve this.
You're talking about Operation Smile. Is that?
I'm not sure, but
there you see the power of community organization.
yes.
That is where the power is. And you still need technology, because actually we work with them. You still need
Of course
that to bring them together in a coordinated way. But without community organizations, you will never, and without patients organizations. So you need the communities, the technologies to bring it to a structured way of doing those very same operations in villages. Actually, it's amazing what Operation Smile is doing there.
I'm so tempted, because I was talking with a colleague from Oxford from the NHS yesterday about cleft surgery, and he developed a kind of a computer adaptive test, which brings me to the point I would like to make. I think the consortium is so thrilling and so much fun to work with, although is, and Tanya could speak to this as good as, as I could, we are doing standardization on the technical part, building community, but also psychometric is a good timing, because of psychometrics at this point, we are building on also a large investment from the US, the Promise framework, which has invested hundreds of millions to have an interoperable system to make PROs. So we are also in this next step. It's not that we are using a standard questionnaire like in the old days, so we have a modular system in mind which we are using, and this also comes back to your original question. So it's not just that the technology will help us, but also to capture the signal. I thought, well, it's very similar. You ask what patients you are, but if you have an elderly patient, then you have some patients, as Mini just said. And when we started in 1995 with first ePro assessment, the first patient was 84. So, and she was able to do it, but we have others who are not. So our psychometrics also will be prepared to give you smaller sets of items, still capturing the signal. So as you use different thermometers in different circumstances, if you have enabler patients, use a different thermometer if you're on a regular ward. So that's what we do also here. We will be able, using also new psychometrics, to give an elderly patient maybe only 2 questions, where younger patients can answer 8 questions. You get a more precise measurements in one case, but you still get the signal, which is more than no signal.
Super. Thank you very much.
I only want
go ahead.
I only want to emphasize that thanks to H2O, patient organization are involved. So we are realizing about these barriers, and we are going to identify them and propose some solutions. So part of this problem is going to be solved before we starting to collect data. So I hope that it'll be fine at the end.
Super. I mean, we've actually started talking about them, but I wanted to pass to Herco to talk about some of the potential barriers and opportunities. I think we've covered some of them already, but in case there's some other points that you really wanted to get across.
Yes, many have already passed, and I think there's on the opportunities and barriers, there's another 2-day session that we can do easily, I think. Now, I think one of the core challenges, I think, is one that Tanya also addressed, is it has to become a real learning community. And learning is difficult. It's not as easy as you think. You have to do at least a 3-step approach. And that's, first you have to share the knowledge, and that's where we are very good at. Then you have to change the attitude, which means that everyone needs to consider, what does it mean to me? And what are the consequences for me? Just to have that thought process is a very important step in that learning process. The third one is you have to change behavior. And that's the most difficult one, because then it also becomes very personal or bureaucratic, or not just and bureaucratic and financial. And but I think that if you really want to make this this whole community at the local and national and European level a success, you have to go through all these steps every time. And I think, well, that's where the main challenge is. The pitfall, I think, is what I call the 42 problem. And I'm not sure if that resonates, but
Galaxy.
Yes, The Hitchhiker's Guide to the Galaxy, the book where the characters come to a planet that is a supercomputer that has been calculating for millennia on the answer to the ultimate question about life, the universe, and everything. And the answer, the computer says, is 42. And it knows it very sure because it's been calculating for this for a long time. The people who programmed that computer have already died out millennia ago. So the pitfall here is that we think technology is the 42 answer to our ultimate question about life, the universe, and everything. And so it is about going from the potential of all this data that we have and all the technology that we have to actually providing evidence and learning from that and building the learning system.
Super. And maybe I can turn to you, Herwig, online, get your perspective on the opportunities and barriers you've experienced already from the Austrian perspective.
I mean, you know, currently we're still enthusiastic about the project, so no barriers visible, but obviously there are some. I think what we have to manage to achieve is a good balance between the various potential benefits of the project. You know, the public system might have a different perspective to the clinician interacting with the patient, as well as to the industry. And I think we have really tried to balance these different views and perspectives, because obviously also the benefits for the public system might be different to the benefits for the industry. For instance, patient-reported outcomes might also serve as a measure to identify over-treatment or over-diagnosis. And actually, to some extent, I want to challenge the idea of early diagnostic. You also have to have an efficient therapy. So we do have strong hopes and in this project, and as also my colleague said, technology is an important issue, but it's not the solution in itself. And so there are, to some extent, also competing interests in this project when it comes to the ultimate aim. I think we can, to some extent, solve these competing interests when we agree on a public benefit. But of course, this public benefit or benefit for public health systems has to be negotiated constantly. So this might be an obstacle we come across. And I think as long as we are aware of these competing interests in first place, I'm quite confident actually that we can balance also this issue.
Thank you. And then maybe I could turn to Roberto again from a Spanish point of view. What are the opportunities and barriers that you see already from the work you've done already?
One of the problems maybe is to how to solve the technologies issues, how we are going to integrate everything together and start to analyze the information. But other problems that I'm really worry about is that there are one thing is to speak about PROs, another thing is to select the right proper way to collect the PROs. There are a lot of instruments to collect that information. Some of them address the same topics, and the result of those instruments not always are in agreement each other. So that's because the purpose of the researchers was different when they were designing the instrument, and we need to be very careful with the selection of those tools. So for me, that is going to be part of the success we are going to have, and is maybe one of the main challenges.
Super.
Can I jump on that a little bit? I think I would add to what's been said with question or a potential barrier or an opportunity. I would call it an opportunity. In this promise of bringing patients as participants in their own cares, we also must bring clinicians, because they're the other partners. In a patient care, you have the patient, you have the clinician. And bringing clinician on board with this methodology, I think, is going to require quite a bit of effort and quite systematic and enduring, because things have been done in a certain way for a very long time. And just as technology, Manny, I remembered what you said, is we're writing the rules of the game. This is not about technology driven, it's about needs driven technology. So in the way in which we can harness the potential of technology to serve the public interest, it's also very important to work with, at the clinical level, with clinicians, to integrate this way of thinking into day-to-day practice, because that is where the difference is being made.
And I see a sort of question that's come in that's related to that, where they talk about who are the practitioners mentioned that are important to patients. Are these only physicians, or are we talking about other healthcare professionals like pharmacists or even carers? They're not. Does this vary? Who's important to the patient and who they trust across various countries?
Well, the first point of entry usually for patients is their regular healthcare provider, their doctor, their GP, their pharmacist, the first point. But this is a systemic thing. This goes into hospitals. This goes into national healthcare systems. A patient with, for example, the case studies is examined in this project, they usually require multiple specialists, right? So we're talking about the broader healthcare practitioner, healthcare professional community, doctors, nurses, hospital management.
Mm-hmm. Yeah. Any other points of view on that? No? Okay. My next question really is addressed, first of all, to you, Professor Rose. How can the H2O practically unleash the data?
Well, yeah, I think Deepak described this so nicely that I shouldn't add anything, because I cannot make this better description like he described this. But the practical, I think the view came pretty clear, and I think we heard also from Austria the perspective. We at the moment at the H2O, I think we firmly believe that the synergistic potential gives more than the pieces. So if we are all, working in our silos as scientists, as pharmaceutical industry, as regulators, it's obviously the work is much easier. So and there's always kind of a draw, and sometimes we talked about there are some competing interests, but I think the shared vision is we feel that it could be a different thing what we are talking here. It could be something more than the pieces. So the practical need, I think, or the practical work will be obviously building, as Herko just said, first building the infrastructure, which is kind of groundwork where the rubber meets the road, which is laborious. And I think we can go to the details there, which we need to, in each of the hospital system, which will be different. The Netters here, in the Netherlands, where we have the DHD, which is already pretty much established. We have the supercomputer in Barcelona. I don't know. I'm just looking to our colleagues. So it's a different story there. And in Germany, we do have other systems where we really well, try to include as many structures. I read another question here on the chat, which is also asking about the German system. So we will create the infrastructure first to enabling this, as Deepak, I think, laid out very nicely, as a laboratory result. So as a prime encounter from the patient to the physician. That's the starting point. It needs to be useful, actionable, like routine lab data. But that's good. That would be good enough, and we wouldn't need an H2O project. We wouldn't need government support. That will come anyway. But to build it beyond that, the practical use beyond that is, make sure that we can analyze the secondary data and the real-world data evidence, and that's just not PRO perspective. That's a challenge also for the other clinical data. It's not our problem. Probably we show a use case where we can use the European health data space that we say, well, this is a good idea. Why is this a good idea? Because we would like to transform medicine. And this might not be modest, but might still be needed. So the practical thing, very easy, treat it as a lab result, build the infrastructure, which I compare to lab is easy infrastructure, comparatively easy. We are used to good working labs, but when you think of a lab, how much infrastructure had to be built? You have to have a kind of a printer, it needs to be a QR code, you have to have the tubes needs to be delivered to the lab. Think of this here now, Elena is just doing this in a click, if she says, well, do the programming, I need to have it in a week, then probably she does it. Maybe it's 4 weeks, but
Yeah.
no, I'm just saying this, the technology, everybody has the smartphone ahead. So to collect the PRO data is the minor thing. And the rest we just built on the infrastructure for so many smart people already investing this to integrate EHR data in the European data sets, which is a hard stuff, but it will come anyhow. So we are building on this, and maybe the H2O is giving a little bit more meaning, and the meaning is then focus. And this is maybe a Trojan horse also. If we are using the PRO, we will force the medical system a little bit with measured data to focus on the patient. And that's not none of my physician colleagues, they don't want to, but at the moment they are measured by other results. And that's, what measures gets been done. That's a kind of trivial thing, but we help them to have, again, meaning in their life. And I think that, at least in Germany, I don't know about the other European countries, our challenge in healthcare, is that we are losing the people who want to work there. So first of all, we have almost 15%, missing people. We cannot, we don't have the nurses to work there. And this will, physicians are not so happy anymore with their working places. Not that they're not well paid. It's just that the meaning is kind of lost. And I don't say that the H2O will give the meaning again, but I think I firmly believe that, the core heart of a physician and maybe also the patient is, to treat, you're trained to make people's life better, not by any kind of surrogate parameter, which we are so used to, like 6-minute walking test, regression-free survival, stenosis, of a heart, which is all fair, but we assume that the stenosis or the 6-minute working test is relevant for the patient. And of course it is, but not as much as we think it is. And this is the transforming percentage. So practical, treat it as a lab result. Next step is make the lab results available like all the other labs, and then the rest will follow automatically.
And is it viewed already in the same way as, I'm doing an analogy with approval of medicines, where you must have the gold standard randomized clinical trials, and real world evidence is sort of seen as a sort of second class citizen. Is this patient reported data viewed in the same way as the other data you have from labs, etc.?
Oh, absolutely. There are much more people from the pharmaceutical industry. I think all the majors are here, so they would know how much labeling claims are connected with making the lives better. So meaning that the patients, that is important. That's PRO. That's where all 30 years of research, where the instruments are coming from. So we have to transform the instruments, as I earlier said, to make them available for clinical practice, which is a little bit of homework. So that can be done. So the ultimate, that's really the vision, and I'm not really sure if I'm retired by this vision, but it is, of course, we all would love to run RCTs on RWE, on real world data evidence data. That's the ultimate goal. that's but what Deepak said. Well, we start with something which is totally natural. Take care of how the patient feels. My patients, that's cool. But then in the end, if the infrastructure is very lucky, and we are in fact, maybe in 10 years sitting here together and celebrate what we have done, then maybe in 10 years we also have an infrastructure where we can RCTs, which is obviously the ultimate way to, to create evidence, but not in big university hospitals like ours, which is nice. Again, it's a zero. It's easy for us to handle within the Charité, but it's not meaningful because we have a selection. If it comes to rare cancers, probably we are good because we have most of them. But if it comes to other diseases like diabetes, we are not good to do this. It's not. We have to have other structures to make meaningful results for this and to run on real-world data evidence data, RCTs, maybe 10 years. That's cool. That's cool.
Okay. I was going to ask, because you've talked quite eloquently about the role of the doctor and how that's going to be changing as a result of H2O. I wonder if I could ask Roberto and Anka about the role of the patient and what difference the H2O will mean. I suppose being more proactive about your health is one of them. Roberto.
It's part of what we have already said. If we assume an active role, we are reporting, we are analyzing all that information, of course there is a benefit. We still need to educate patient, physician, because this means a change. But at the end, what we are achieving with these changes are, I would think, something we were deciding to get. So for me, it's a good thing. It's not a problem, and our role is changing. We are assuming it from a few years ago, and everything is okay.
Super. Thank you. So, Anka, did you have anything to add?
Yeah, I think, we're moving away from a patient following doctor's orders to a patient and a doctor working together to create a plan, to make a plan. And that is really, if 50 years ago doctor's orders would have worked, I don't think it's as easy now. And having a plan with shared ownership that is based on really that person moves us from treating a disease to treating a person, and having that person help with their own health within their own ability, and making their informed choices about what works for them, what doesn't, how they balance risks and benefits for their own person with as much information from their disease community as possible.
Super. Yes.
Yeah, maybe to add to that, this isn't because we're now talking about the influence that H2O might have on that relationship, but everything is changing for everyone, and this is just the tip of the huge wave where everything is moving right now, especially in this space. There's never been this much money being invested into this space as it is being done now as part of Building Back Better or resilience funds, or so there's that. There's never been this much political will to fundamentally change health systems worldwide. It's not just small incremental changes, but fundamental changes in health systems. There's never been this much felt and experienced need for global collaboration on this. So I think with all those, and the technology has proven that it is able to provide to the needs that are now being expressed everywhere. So I think with all those ingredients there, this is now the time to do this, and that's why you see this change, not just in this project and in these observatories, but patients will be enticed and enabled and empowered and maybe even cajoled a bit into changing their roles. And the same goes for doctors, and the same goes for regulators, and the same goes for industry. And so everyone's now in flux, if you will.
Super. I see there's a couple of questions coming to repack, but before we go there, maybe I can turn to Yasmin, who's been sitting patiently here. and ask her to kick off talking to us about the H2 model for other countries, and can it be replicated beyond Europe?
First of all, thank you. It's really a privilege to be on stage with you all. Amazing work that's been done. Short answer, yes. To give a little bit of context, the forum really prides itself as being the international organization for public-private partnerships. And so we do that by bringing all of the stakeholders together: civil society, patient voices, private sector, public sector. And our mission, which hasn't changed in the 50 years since its inception, has been to improve the state of the world. So easy task, right? But we do this really by using three main approaches. The first one really by building awareness. You have to know what the problem is to really elevate the issues to global agendas. Secondly, let's build strategy to make informed decisions together. And then thirdly, based off of really understanding what the problem is, the strategy, let's do actionable impact. And so at the forum, we have a health and healthcare platform that really does look at healthcare system transformation and is really dedicated to understanding how value-based healthcare can help accelerate a lot of these issues. And in our work, we've really looked at the levers of change. What are the pushes and pulls that we can address to really make transformational change, not just incremental change? So we've looked at payment reform, reimbursement mechanisms, care delivery models, improving interoperability and informatics, how all of those things are intertwined. But there is, of course, a foundational element, which we've all heard today, which is really this baseline of the urgency we need to have data, evidence-based data that really speaks to the needs of patients. And not just the data, but backed by strong governance, a really big backbone and framework that we can base it all off together. So hearing you all today, it's just amazing the great success that H2O has been showing as an initiative in pathways for countries and in very different healthcare system architectures. So congratulations again. I think that it's really important that we have measurable outcomes to really eliminate the waste in expenditures and with our over exploding budgets. So I think the forum would love a place at the table because we could help elevate this to a global platform, use the strategies that H2O has shown as lighthouse examples to really help other regions, other countries make informed decisions, and then really use that global scale, that global platform to scale. I think it's amazing what the work has been done, tailored approaches to each ecosystem and environment. So all to say that the forum would be wonderful, happy to take place to really amplify and scale these issues.
Super, thank you. Herco, I don't know if you have something to add from the diversity of Europe and how that can help other regions because of that diversity. Perhaps.
Yeah, and it's also one of the questions in the slide that I see. So one of the things that is coming is this idea, at least, of a European health data space, which is still a legislative proposal that is now being discussed. So it's still very much in development. But there you see that we're building on the same common human values, and that then we elevate these to European values, the framework that is very much in line with what's happening here. And setting that and using the strongest European mechanism that we have is a European regulation, and basically creating the legal framework that will allow this to fly throughout the European Union and beyond. Because that's, to your point, I think if you look at what the GDPR has done globally for privacy, it's raised the bar globally. Yeah. India has done it. Indonesia is doing it. Even the US has 21 different versions of GDPR-like regulation. So they're now even considering a federal privacy bill, which is very special for the US. And if you look at what's happening with the European health data space, but also with the other data regulations that are now in Europe, the Data Act, the Data Governance Act, the AI Act, and some others, then this will elevate and raise the bar globally on how we do data governance, and especially then with health data. So that's like I said, it's a huge wave that's now coming, and I think H2O is really at the forefront and riding that wave.
Super, thank you. And maybe we could turn now to those questions, Deepak. I don't know if you can see them, but I'll read the first one out. Having multiple apps can lead to administrative burden for patients. Is it possible to integrate multiple use cases into one app?
Thank you. That's a great question. So let's start from the perspective that many mentioned briefly, which is that we made a deliberate decision in H2O not to pull out the screwdriver and the hammer and say that a project should build the outcomes app for the planet. What we instead said is we are going to pump, prime, and steer the market and encourage innovation and creativity. That's deliberate. And so to some extent, the answer to your question is not in our hands. It's in the hands of how the market evolves. We recognize at times there will be best of breed apps that focus on a single condition and really deliver a whole range of added value knowledge services that go beyond the scope of H2O and make the patient experience of that app superb for one condition. And it would be wrong for us to say that's not welcome anymore. Equally, the idea that if you have, as we are all getting older and accumulating long-term diseases, if you have 3, 4, 5 diseases, that you have multiple apps, you enter your blood pressure or your body weight into 5 different apps because they don't talk to each other, that's going to be frustrating too. What we are wanting to achieve in H2O is to open up this opportunity space to work with the innovative sector in ICT and with patients so that we guide the market in the directions that are most favorable. I don't think we should dictate that one app should always be the best solution, nor should we dictate that each disease has to have its own dedicated app.
Thank you. I think Elena and then Manny would like to add to that.
Hi, it was on before, is it? Okay. I think what Deepak mentioned is very important. And actually, there are ways in which you can simply query data that has already been stored somewhere. You don't have to ask the patient to put it again and again and again. And I think that's part of the governance, right? What are the things that, if possible, if you know that the patient has already shared those, you're not going to re-ask it, but you call it through an API, not in the way pharma calls the APIs, but really right with a programmable interface. And that, I think, could become part of the governance, because governance can be in terms of who does what, who steers the data, how, but also what is the backbone of reusability, right? So, and from there, then the technology is morphed on it, not the other way around, because once you set the rules, technology complies.
So it's humans, as usual, that need to be sorted out.
No, I just wanted to make sure that I could see that Elena was, that's what I wanted to.
Okay. All right. Can we pass to the second question? By the way, if you have other questions, put your hand up or use the Slido. If you put your hand up if you're in the room, and use the Slido in any case. Deepak.
I have a question as well.
Yeah, go ahead.
I have a question for the panel, or for Deepak, or I mean everyone. But if you're successful, and let's say you will be successful, how do you make it very explicit? What is the benefit for society as a whole, and how do you exploit in a way that is appropriate, right? The benefits of the treasure trove of the data. And I'm not saying it in a cynical way. I really believe that we need to be thinking ahead of what's the benefit for the patients that clearly give the data and will have a feedback loop. What's the benefit for the cohort of patients that can have, insights at population level? What's the benefit also for the health systems that are enabling this type of work, because they can do much more targeted interventions? What's the benefit for some of the pharma that support the project that can do better R&D? But is there almost a charter of expressing the benefits of precision health? And Deepak has done amazing work on manifesto and other, how is it called? A covenant. Compact, yes. But stating the benefits very clearly associates and federates people. And I think that's an important element, because people want to share and contribute to those benefits.
No, I think it's absolutely essential. And I don't know, that was an earlier question I think we touched upon, was how do you actually get people on board? And how do you show them where we're going, where the light is at the top of the mountain? And would that help, I suppose, is a short answer, to have that compact and to have that as your manifesto, as it were. Any views on that?
You first?
Yeah, I go first.
No, I was thinking about how important is to, and this is part of the discussion we already have with the government, sustainable health systems are a priority for us. If we can have a system that use reliable information to make the best decision to cover the real needs, medical needs, we are doing something good for everybody, because we are reducing a necessary visit to the emergency department, for example. We are reducing costs. We are optimizing the treatment for everyone. We are reducing the budget of the health system.
Are you able to prove that? Because we're at quite a difficult ebb at the moment in terms of economic stringency. Yes, go ahead.
So yes, that is part of the project. That what will come at the third phase of the project, I think as Tanya actually alluded to at the beginning, is what we call the impact study, which is where we will, through the project and through her leadership, we will show what it is the value that we may be creating or not for the various stakeholders in a systematic way. So that is part of the project. But I think what Elena alluded to, which is a fair point, is that we do actually have what she asked, which is our governance principles. And we have our governance principles, and we have our constitution agreement, as we call it, which is the rules of the game, more or less, of how this all comes together. I think maybe what we still need to do is to make this more public and more layman helpful.
Yeah.
My boss asked me the other day, H2O in a box, please. I think, H2O for dummies, because he says if I ever need to speak about it, I don't have a way to actually just quickly explain what it is. So I think that's in our to-dos. Thank you.
Maybe I can add to that, because I don't think we have an alternative. The pressures on healthcare are so big. The challenges are so big. And it's not just in one country or local, it's everywhere. And everyone knows that we have to go into this direction. So I don't think that there is any doubt anywhere that this is the way to go. And now it's just finding the right path instead of, is this the right path? And you see that with for instance, the European health data space regulation. There is no way back. So it's not just an experiment and we explore whether or not this is one of the good options. No, the direction has been chosen already. So in that sense, I think that's a big part of the societal business case, or that's already been done. And questioning that time and time and again will only slow us down if we keep doing that.
Yeah, I think what we're talking about is health as an investment rather than as a cost, which I think needs a lot of education still. We're seeing that in the discussions on the health data space. Member states like the theory, but the money is the issue. So Deepak, I don't know if you're ready for the other question, which it seems to me quite technical, but maybe you could explain it to me. In the National Observatory, does data residency, perhaps you can just explain that term, need to be within each country?
Well, if you think about, we've spoken already a few times today about the European health data space. Within the European Union, there is a homogeneity about the rights of individuals to have the ability for their information to move if they travel. And in one of my slides, I mentioned the patient moving from Spain to the Netherlands. So it is important that an individual can experience the benefit of being a European citizen and have that portability and movement of their data, which is already a long-standing right of citizens, that if they fall ill in another country, all of our member states have been building up the capability to move emergency data, the medical summary, from country to country. So H2O is building on a momentum and a set of citizen rights that already exist. We are not pushing boundaries here. We have still to explore the interoperability standards we can use. We can build on the European Health Data Space proposals for an exchange format and so on. But I don't think we are risking anything by suggesting that if an individual moves and wants to have access to their data in another country, that we do that. The moment we say, let's put all of the data into one giant repository in another country or in the North Pole or the South Pole and say, this is now Europe's data, we will be hitting difficulties, but we don't intend to do that. That's never been our proposal. So each observatory will respect the national sovereignty of where the patient is resident, where the patient asserts that they would like their data to live.
Okay, thank you very much. There's a question up here. Sorry. We're just coming up to lunchtime, so we'll slowly.
Mieke Hazes, the supervisor board of H2O for the Netherlands. We are talking about sharing and making available the data, patient-reported outcomes, and also to connect it with clinical data. But if you look at patient-reported outcomes, and Matthias, you already said that it is in a way not always representing what's really going on with the patient, with the person, and mostly you can measure it better, as we already know, by your watch, your smartwatch. And my question is, in how far is H2O the rules of the game as to technology and privacy, also including the possibility to include personal measures, physical measures, because that's the future. The prompts, in a way, are prehistoric. Well, I'm coming from the musculoskeletal world, and I know that a lot of those prompts, they don't represent really what's going on. They don't measure it. They are not sensitive enough.
Many does want to.
But I think Matthias is.
Yeah, Matthias.
No, I think that qualifies you certainly to be in the position you are in H2O, that you have the long-term vision, which is good, that you feel that you're also prehistoric. So I would probably argue with this, and maybe in the very end, they probably we can revisit it. I think at the moment they are tremendously important. Maybe just to stress this, because it is maybe to use also the forum in a way. It captures, and then coming back to your question, I think it captures the single, like we monitor our health every day. You know, that's the reason why, physicians like us, how do you are? And then we know by, answering the questions, we observe us. And this information, is not used so far either for clinical practice in a systematic way, nor for research. So that's the basic. So we are capturing this information, and as clinicians, sometimes you transfer people to intensive care, although they have the exact same biomarkers, but they say, well, no, I don't feel well. And then you say, well, better be cautious. And there's a large, from Quinton et al. A couple of years ago in cancer, which has shown that PRO data are predictive for mortality very strongly over 5 years. And there's recently another study from Eisler, a German group in sarcoma, 1,000 sarcoma patients being published, to again 1 year follow-up to show that the people who have reported loss of appetites in the encounter, like now, it separates from the people who have not loss of appetites and physical function, and so about 50% difference in the prediction rate of mortality. So it is a very, very strong predictor. Clinicians know this already, so patients know this already. So it is
the personal level of the patients I'm talking about. I totally agree.
Yeah. So I just had to feel that my emotions are going up. So now I'm relieved. So it's a strong.
Your remark about the 50 meters walking time. What does it mean? So it is
absolutely that was
questionnaires.
Absolutely, there is a discrepancy, and some of the doctors have sometimes problems because they are asking us, being in the H2O, what is the truth? So if something, and even if you do this with vision, and this is not H2O, it's just 50 years of 15 years research. If you say something, you have problems with reading, and then you say, well, I do have or not, and then you compare this with concrete objective measures, and the same with heart failure, so on. So you always have a discrepancy, and sometimes the correlation is maybe around 30. So your experience of your health set is not the same as we measure. So is there truth? No, there are different perspectives. This obviously gives a better picture, which helps us probably to have the better treatment depending on the deep phenotyping based on the experience and the measures, the physical measures, and then thinking of the outcomes. And the outcomes is a transformative part, because the outcomes, I think, in the end is, in any case, how the patient feels, how long he lives. The patient, that's an outcome. But now we are talking about different things. We are using the patient health reported data. That's probably even a better term than PROs. That's health reported data, and how they fit inform us a little bit more. And then, to come to your question, shall H2O or any other project shall also use kind of more direct assessments? And yes, one of the SMEs which we have included for the reasons, because they have a kind of a strong history, technical history, how to use sensor data to do this, and the diabetes is a use case. So I totally agree with you. But again, I think it just completes the picture, and it completes the picture because you can monitor data from ambulatory care, either directly measured, but still, and maybe it's a psychotherapist typical approach, that the thing what you feel entirely from yourself, it's an emergent idiosyncratic thing. So it really describes yourself, which you only can do independent how technology will go on. I think we are always better to say, how are you? And I can.
How are you? And the prompts are.
Oh yeah, absolutely.
Perhaps we can continue this over lunch.
Yeah, sorry.
We're eating into lunch now.
I think Matthias gave a perfect answer. From what I just wanted to say from a conceptual point of view is that we're talking about the rules of the game. Yeah. And Matthias also used another very interesting word earlier, Trojan horse. The Trojan horse. And I think that's a very clever way of describing what it is we're doing, because we're building on the PRO, but really the ambition and the intention is to bring all these other measurements in. But the way we're going to do it is by showing the success first on something which we can control better, because at the end of the day, if you think about it, and that's how I think, because I'm an antitrust lawyer, that's who I am. How are we going to create the environment and the rules and the triggers that will make the likes of Apple or Fitbit also share this data with us, right? So to make that happen, we need to create the rules that will make this happen. And this is not just a matter of mandating, it is also a matter of creating the type of framework that will help them or will incentivize them to do it, because, and that's very important, technology performs much, much better when there are incentives. Once you mandate technology, you get the absolute minimum boring solution, which is not what we want for health. So we need to find the right type of formula that will incentivize technology providers, which at the same time will allow us to have to get this data into the observatory.
Which brings us very, very nicely to lunch, which we now have, I think, 39 minutes to consume. Fortunately, you don't have very far to go. It's right out here, I understand. And we are coming back. We've been talking a lot about patients' views and patients' feelings. We're coming back to a second panel, which is going to talk about patient-centered partnerships and bringing the European health data space to life. I'd just like to close by thanking all the panel here and showing our appreciation for also the panel online.